This is John Kanellopoulos from our office here in Athens, Greece. Very interesting case. 74-year-old lady. You can see a very significant cornea scar in her right eye. Vision is down to hand movement. She also has a very significant cataract. She's pseudophaking in her left eye. Since 6 months, we're seeing here the anterior segment OCT thinning over the scar area, and of course, significant thickening of the epithelium on the epithelial maps to the right of this OCT image. Sine fluid imaging shows a significant flattening expected in the scarred area and rebound steepening next to that. But note here on the placido disc images that the central flattening resembles a laser ablation with significant regular astigmatism centrally. Unfortunately here, an added problem, low cell count, we're right around 1,000, 1,200 cells per centimeter, millimeter square rather, and patient is stable. These are the anterior segment OCT images in a 2-year span, 18 and currently. The Tomaine interferometry shows significant astigmatism. These numbers give us a T5 lens. We're using the lens star measurements here to compare right eye and left eye. You can see the left eye lens is just 0.6 millimeters. The right eye is almost 4 millimeters with a cataract. And we're going to use the ACRS calculator for post-refractive surgery to calculate this lens because of the significant central flattening due to the scar. This is now our 6 o'clock marking seen here, which is seen upside down. We show it in the OR to orient ourselves, and I use that for my toric IOL marking. And we're in surgery. You can see there's a little bit of a second rotation of the eye with the peribulbar anesthesia. I'm going to set my toric marker at 24 degrees and then ink the marker. So we're going to use a very high power T7 toric intraocular lens at 24 degrees, and again we use the calculator to overboost this lens since the central flattening from the cornea scar may resemble the one seen after laser cornea surgery, and we can end up with hyperopic surprise. So here, back to our patient, we're going to mark the 24 degrees on the cornea as seen here. We're using that 6 o'clock marker and the vessels at the 12 o'clock position. A 275 keratome, a beveled clear cornea incision. Pretty easy visualization, is not a problem for the incisions. It'd be impossible to use a femto here, by the way, to perform a capsulotomy, and then using the same blade for 1 millimeter paracentesis, using diluted epinephrine to attain a little bit more mydriasis. There's a very small pupil for the density of the cornea scar, which is central, so I'm going to maximize my visualization. Peripheral to the scar, I'm putting air in the eye. You're guessing correctly because I'm going to follow with blue dye to stain the anterior capsule, maximize my visualization, and of course tighten the anterior capsule, make my capsulorhexis easier. I'm nicking here the capsule with a cystotome, unfortunately right at the area that is most difficult, and then I'm going to enter with the uterine forceps. One thing I have to confess to you is that the view we're having here is 10 times better than I did have intraoperatively. This was very, very foggy, and I'm impressed in how clear it looks in our video. But in any case, I'm using my uterine forceps. You can see the very nice tightening of the anterior capsule attained with the blue dye, and of course how well it delineates my capsulorhexis. I'm at a point where it's relatively easy, and now we're going to dive into the very difficult, an area of unknown. We're basically doing this with our eyes closed, and I'm not sure where the edge of the rhexis is. I'm going here with pure habit, regrasping, and bring that capsulorhexis edge within my visualization now, and then completing the continuous curvilinear capsulorhexis. The rest of the procedure is relatively straightforward. Unfortunately, the lens was not extremely tough. Following hydro dissection, I'm using the cannula here to spin the lens and kind of detach it. It's quite sticky, as you can appreciate here. So rotating the lens in the bag is certainly a good idea in my opinion. In with my phaco probe, I'm going to create or sculpt rather a central groove, crack the lens centrally, and then each half here I'm cracking the lens into halves, and then I'm going to further crack the two halves of the cataract into 4 quads. And again, just while we're in the routine part of the procedure, you can see that I'm bringing everything to that clear window that I'm having infranasally. And basically I'm doing all the procedure through that little tiny window, as the central scar is quite distracting, and as I mentioned before, during the procedure is creating a lot of glare, so it's making the procedure difficult. My ideal approach to this patient would have been to laser first to reduce that scar, because we saw there's at least 500 microns of thickness, and then proceed with the cataract procedure to also adjust for the possible refractive change that scar reduction phototherapeutic keratotomy would have produced. Of course, a penetrating graft combined with a cataract procedure is another option. We went backwards because of the patient's final request. Patient and her daughter, family is very significant in Greece, decided to do the cataract first, see how the vision improved from there. Remember, this eye was hand movement prior to our cataract procedure. The other eye is 20/20 and pseudophakic. I'm at the removal of cortical material. And again, some of the views here are very limited, working more habitually and with the red reflex visible at the borders of the central cornea scar. We're done with the cataract extraction and cortical removal. Methylcellulose here, we use Viscoat for initial procedure to protect the endothelium as much as possible. Methylcellulose to fill the bag, and here is our T7 lens. Again, we use the ACRS calculator to avoid a possible hyperopic surprise on the calculation of the lens in this patient, because the cornea topography resembles that of a cornea intervention to reduce myopia with a central flattening. Lens is in the bag, and the second challenging part of the procedure, actually the third, IOL calculation, is a challenge in these very irregular corneas. The second was the procedure itself. The third is to line up the lens markings. This is the Acrosoft T7. I'm not sure if T7 is available in our US practice. I know in Europe we go from T2 to T9. I think the US goes up to T6. My call to attain meiosis. We're essentially done. Hope you found this case interesting. This is John Kanellopoulos signing out. Thanks for your attention.